the same sequence. Autoimmune conditions, they have also their own way of doing it, and it's very easy. The third one can be spot diagnosis cases. They have a certain pattern, and there is the acute or the emergency medicine part. And lastly, we have the vision in station 5 or the ophthalmology cases. Remaining beyond all those, going to be from 4 to 6 cases which are sporadic, that do not follow a certain approach. And those are quite easy to be done. So this is the general outlook of station 5. So the final look there, and we will start. And yeah, everybody went for, most of us went for 57% went for the station 5 long case MRCPI. So let's make things more interesting. You know how much I like those cases, and we need someone to start the first case. If you want to, kindly unmute your mic and tell me your good name. I prefer, of course, someone who did not. Dr. Suraba. Perfect. If someone else wants to do the case, let's go. Dr. Suraba, I guess you did a case with me a couple of days ago. So if someone else wants to practice, perfect. If not, we can do it together. And we have Dr. Muhammad Ratata. Let's do it with Dr. Muhammad Ratata, if you allow, Dr. Surata.
Oh, yes, sir, please.
Dr. Muhammad Ratata, my friend, I hope that you are doing fine. And we had more than one day or one session together. We have known each other for a while. So let's give you one good, interesting case.
Okay, Dr. Muhammad, how are you?
Station 5. And we go with. Hold on, let me get you a good one.
Okay.
Okay, so we have a 25 years old lady who has been complaining of red eyes for the past 3 weeks.
Okay.
That is going to be your scenario. Or let's make it more interactive. Let's do it with the traditional standard kind of pitfall for the basis exam, and I hope that you will get it right and perfect. Otherwise, I will kill your headphones, my friends. And this is a 55 years old lady. Her name is, of course, Mrs. Stewart, and she came from Uranus. And the lady has been complaining of blurred vision for the past 1 hour. That's station 5. Her past history includes diabetes, hypertension on treatment. So this is one vision problem. Do you agree? Do you copy?
Okay, I have 8 minutes.
No, you have 5. Yes, I'm just kidding. Take your time. For the time being, till we prepare our paper. Before getting to know, let's mute everyone for the time being and unmute Dr. Tata when you're ready. So station 5, as any other station or the long case of the MRCPI, you get 5 minutes before seeing your patients or surrogates. You get 2 scenarios at the same time for the MRCP, in between which there is no rest. So make sure that you have the 2 scenarios in hand, use one piece of paper, and divide it in the same way we did for station 2 and station 4. It's good to have a system. On top, I'm going to write down the name and the age of the patients. Next to that, I want you to write down the presenting complaints. This is going to be side A of the paper. Then items of the history that we need to cover, which are the social history. If someone can share the scenario in the chat, it would be awesome. Past history, medication history, with or without family history, depending on the case. And I'm writing those down for both sides, side A and side B. Then I have an approach for the case in hand. I wonder which approach fits with this case. Definitely the vision problem. Then I would flip the paper on the other side. That would be side B. I would change the name. I would change the complaints. The items of the history are the same, and the approach depending on the case. Keep in mind, one very simple Chazook, since everybody knows what is a Chazook by now, or a pitfall by now. that one of the major problems in station 5 sounds very easy, but writing down complaints, looking at the complaints is a major pitfall, because inside you may forget what is the presenting symptom and you may be distracted by other findings. So please write it down clearly in front of you before you start. Generally speaking, whenever there is a station 5 case or the long
This
case of the
young male
MRCI,
patient has a largely normal cardiovascular examination, aside from the presence of a device implanted.
this guy has brilliant English. I'm sure that he's British. Anyway, moving on. So, generally speaking, we start with the presenting symptom or the stem of the scenario. And we know how to do that in 8 out of 8 points. And from now on, everything will be in points, no paragraphs. Then I'm going for the system involved. If this is a case of a diarrhea, I will go GIT, headache, I will go CNS, and so on. Then I need a proper differential diagnosis in order to reach a diagnosis, keeping in mind that the whole station 5 is 8 minutes long. So we will put it as 2 minutes for the history, 2 to 3 minutes for the history, followed by an examination, which ideally should not take more than 2 minutes. Then the items of the history in order to offer help, and those will take further 2 more minutes. And finally, we have a closure. And the closure effectively can be done under 30 seconds up to 1 minute. Then you get 2 minutes discussion with the examiner, and you shift to the next case. That's a total of 10 minutes per encounter so far. But hopefully they will change that later on, because this is the worst type of scenario. So this is generally speaking how to do things when it comes to station 5. The only difference between the long case of the MRCPI and the MRCP would be in between station 4 and station 5, I need to do proper systemic review. System by system, question by question, to make sure that I'm not letting anything go unnoticed, because you have time in the long case of the MRCPI. This is the general approach for station 5 and the long MRCPI. And yes, my friend, you get to get only 5 minutes before the start of the examination in both cases. And furthermore, I would tell you, being a little bit more stressful, the exam, one of the doctors asking, do we only get 5 minutes before the case? Yes, you do. 5 minutes for 2 cases. And whatever the presentation outside can be a completely different story inside. So it's all about your ability to adapt to the situation, to be able to recall what you need to recall in the time frame without looking hesitant in front of the examiner as if you are doing that for your entire life. And that's why I always focus on points, approaches, and no paragraphs. What you do with me is what you do inside in the room, and this will make things much easier. Back to you, Dr. Ratata, if you are ready. We have a 55 years old lady, gorgeous lady, Mrs. Stewart. تعبناها الست دي معنا والله. She has a bust, she's complaining of blurred vision that has been there for the past 1 hour, with a past history of diabetes, hypertension on treatments. You will be the senior house officer in the medical department if you wish.
Okay.
Did you write down your paper?
Yes.
I will know if you did not. حاجة ولع لك السماعة. اوعى. أنا مستني لك. حبيبي. Okay. The timer is on and go.
Hi, Mrs. Stewart.
Hello,
I'm
doctor.
Dr. Mohammed, senior officer of the clinic today. We are here today to discuss your clinical condition and examine you.
المايك يا معلم. If you can fix your mic, please, it would be very much helpful. There is a problem with the connection, maybe. I'm not sure. Let's mute everyone.
Yeah, there is. Okay.
Okay. Yeah, back to you. Sorry, carry on.
Okay, ma'am. Dr. Mohammed, senior officer today. We discuss your clinical condition and examine you.
Dr. Ratata, your mic is moving or you are moving away. Something is happening with your mic. Try to fix it.
I will try. Is it okay now?
I think it's the same, but let's try again. Carry on.
I think, Muhammad, I don't know where is the problem.
Okay, now it looks sounds fine. Let's go. Let's reset the timer and from the very
Sounds fine.
beginning. Go. Go, go, go.
Dr. Muhammad, Senior House Office is a clinic today. We are here today to discuss your care condition and examine you. Is it okay for you?
Yes, please.
It came to my knowledge that you had been complaining of blurring of vision. What do you mean by blurring of vision?
I could not see properly 1 hour ago. I lost vision completely in my right eye.
In your right eye. Okay. And this is the first time that this happened?
Yes.
And still till now, there is loss of vision, or it's
It
recovered?
has been restored.
It has been restored. Okay. Okay. And this is the first attack. Is it happened before?
No, this is the first time.
This is the first time. Is this was associated with in the sudden and for 1 hour and then record your vision? Is this was associated with vomiting or
Throwing
headache?
up
Throwing up or
one by
headache?
one.
Okay. Was
No.
associated with throwing up? Is it associated with headache?
Yes.
Okay. And the headache was the start of the loss of vision?
Immediately before.
Immediately before. Okay. There was and it is record spontaneous without any intervention, without doing anything.
Yes, it stayed there for a while. Then it has been better on its own.
Okay. Is this war associated with any weakness in your body? Okay. And is this war associated with any pain in your eye?
Not really.
Okay. Any pain at your joint of mastication or jaw?
Not. I do not recall that.
Okay. Do you have any history of weakness at one side of each
No.
of your body? Okay. Is there any history of back pain or joint pain?
No.
Oral sores or private area sores?
No.
Any history with combing hair or climbing upstairs?
Yes. I have some problems climbing upstairs. I've been tired lately.
Since when there was a problem with climbing upstairs?
For the past few months.
And did you seek any medical advice for this
No,
problem?
I think it's related to my age.
Okay, I'm sorry for that, and we are trying to fix it, Mrs. Stewart. Okay, and you have been complaining of you have diagnosed with diabetes and hypertension before. For how long you have been diagnosed with diabetes?
1 year.
Or high blood sugar?
1 year.
1 year. And what was the last reading of your hemoglobin A1C or blood sugar?
It was 7.2.
Okay, what treatment are you taking for diabetes?
Show me your medication list. I'm receiving metformin, ramipril, and atorvastatin.
Okay, and any recent change in the dose of diabetes or hypertension?
No.
And are you compliant to this treatment?
Yes.
Okay, is there any previous history of blurring of vision?
No.
Any history of heart attack?
No.
Any history of weakness in one side of your body?
No.
Any history of loss urine?
No.
Pain at the back of your limbs while walking?
No.
Any numbness or paresthesia in your hands or foot?
Paresthesia. No.
Paresthesia?
Numbness.
Okay.
Numbness. Paresthesia is jargon.
Okay. Okay. Can I examine?
Sure.
What about the pulse?
Starting from the hands, right? The hands dorsum is normal.
Okay. And the hands, palm,
Normal.
pulse,
Regular, no special character, equal bilaterally, 80 beats per minute of average volume, no special character.
blood pressure,
130/80.
proximal myopathy,
It's positive.
positive. Okay. Jaundice or jaundice.
Looking at your eyes, there is no jaundice or pallor.
Okay. Oral cavity.
Normal.
Okay. Okay. Then I will go to examination of the eye.
Examination of the eye. How would you examine the eye?
Okay. First, I will go for red. I will go for red reflex first.
Would you like to see if she can see?
Yes, yes. The active vision first, bilateral.
The acuity of first. Okay, she can see clearly in both eyes. Intact.
Intact. Okay. And then I will go for after the active vision. I will go for fundus.
Okay, so you would like to do the red reflex, then you will go for fundoscopy, correct?
Yes.
Okay, here comes the fundus on the screen in now.
Okay. Okay, it seems that it's normal fundus.
Maybe.
Yes. Okay, restriction myopathy. Okay. Is there any pain in chewing your food while chewing your food or talking?
I had some problems when I was speaking, yes, during the attack.
Okay. Okay. Okay, Mr. Stewart. What's your job?
I am a teacher.
And how's conditions affecting your job and daily activity?
Thank you. It's very difficult for me to do anything while I'm having the attack, and I'm afraid it will affect my entire life.
I highly appreciate your concern, Mr. Stewart, and we are trying to fix this. And I can offer you help with the social worker and occupational health officer to fix that. Do you
Thank
smoke?
you. No.
Do you drink alcohol?
Socially. 2 minutes remaining.
Okay. Are you driving? You drive?
Yes, I do.
Okay, Mr. Stewart. Till fixing this problem, I advise you that you must stop driving now till we diagnose your condition and starting the proper treatment. And then we can see about what we will do in driving.
Thank you.
Is it
2 minutes
Stewart?
remaining.
What's your concern, Mrs. Stewart?
What do I have? Will it happen again?
Okay, Mrs. Stewart, about what you have, we suppose that you have an autoimmune disease, which is your immune system supposed to defend your body against infection, it affects your body. And so we will do investigations to be sure about this diagnosis. About again, no one can confirm this in October, but we will start
The mic, fix the mic.
Is it now clear?
Yes.
And till we fix this problem, we can I think the mic again.
Carry on.
And we will start proper treatment for this, and we hope that we.
Thank you.
Start. Any other concern?
No, thank you.
Okay. Thank you, Mrs.
Okay, that's a well done case, Dr. Muhammad. However, let's start by saying that me and you have a history. You did take one of the courses, correct? And spent quite some time together. To start with, would you like to know how much would you get in this case? From the very beginning, you're getting 22 out of 28. Can you guess why? What was my concern?
Can you why? What the diagnose and it will occur again?
If it's going to happen again or not?
I said that no one can confirm that it will not happen, but you will.
So,
It can occur again.
so
we will start the
do you
proper
need to do
treatment.
something urgently or not?
CT brain.
What do you think? Let's get back to that. So the message here that I want you to take here is, please pay full attention to what the gentleman or the surrogate is saying. Please listen to the concern and do not hear it. There is a difference between hearing and listening. Here you're putting effort. Please listen, because those are two concerns, not one. Very common in the exam, and this is the oldest trick in the book, and everybody does it. So we will get back to that at the very end. So what is, before we start, thank you, Dr. Mohammed, you have done very, very well. And this is a great effort. Let's fix what we need to fix. So what is your diagnosis for this case?
It's a vasculitis genital arthritis with polymyalgia rheumatica.
أمي بتسلم عليك وبتقول لك واحدة واحدة.
Okay.
My mom says hi and she says, go slower, please. Exact translation. Yeah, حافظ مش فاهم. So again, what is your diagnosis?
Temporal arthritis, okay.
Okay, temporal arthritis predisposed on something else?
Polymyalgia rheumatica.
Maybe. Okay, what else? What is the major differential here?
اللي هو sudden loss of vision, temporal arthritis, idiopathic intracranial hypertension, migraine, multiple sclerosis.
An old diabetic, hypertensive, loses vision suddenly. What else can be the diagnosis?
Retinal artery fusion. TIA, okay.
TIA versus a stroke, maybe.
Okay.
Is it a stroke?
No.
Why?
Because there is no weakness.
No.
And it's recurrent because it's recurrent. It's the vision reversal. So it's TIA.
Yes. And it did not pass 24 hours, so this is a TIA. Is TIA a possibility in this lady? Definitely yes, considering her age, her diabetes, and her hypertension. But why did I put it as number 2, not number 1?
Because there was painful or pain.
Thank you. Because most cases of TIA, and this is the message here that we need to pay full attention to, TIA in most cases, not in all, in 99% of the time, is painless.
Yes.
While there is something else painful, and that's a completely different story. When it comes to other differentials mentioned in the chat. Okay, so to rule out one by one, central retinal artery occlusion, central retinal vein occlusion are not reversible. The gentleman will still present to you with the vision loss. It will not go back to normal. Multiple sclerosis is usually painful and it affects a younger age group. Stroke is irreversible. And this is most of those mentioned in the scenario. So overall, it's a temporal arthritis versus TIA. Can you be 100% sure that this is temporal arthritis just from the history? No, you cannot.
No.
Because you're not a magician. You are realistic. So what do you need to do in order to rule out potentially life-threatening diagnosis like a TIA? The first thing that you're going to do is?
The first thing is CT brain.
No. What is the difference between
MRI?
No. What is the difference between a CT and urgent CT?
Urgent, okay.
What is the difference?
Urgent CT is
pass and fail.
So there is a little bit of, okay, we need to mute everyone. Unmute yourself, Dr. Mohammed. So the difference between a CT and an urgent CT in the eyes of the examiners are the difference between pass and fail. Full mark for the clinical judgment and almost none in the judgment. So make sure, please, that you put it as one word. So the first thing that you need to do, Dr. Muhammad, in this case is
urgency brain.
why do I say urgency? Because this is what people usually forget in the exam, even if they know it, like you have done, and 3 or 4 other doctors in the chat, without remembering the urgent part. Please always remember that. Back to our case. This is a case of blurred vision. Thank you for starting with the proper question or the right question. Blurred vision is a vague, non-diagnostic, or let's say it's a shitty term. It's like fatigue. It's vague. It doesn't mean anything. It can be double vision, it can be loss of vision, it can be tunnel vision, color vision loss, whatever. So we need to be sure where are we standing. So what do you mean by blurred vision? Thank you for asking the proper question from the very beginning. And this is the fact for whatever case in station 5. Before we proceed, let's agree that we have, as usual, 3 sets of papers. One is going to be for your own practice, case by case. One will be set for differentials. You need them handy in a separate paper. And thank you, sir. My favorite kind of paper, which is the Paul's paper or the Khawazik paper, where we collect all the Khawazik. And here we have lots of them. So the first one of the pitfalls or the Khawazik is case of blurred vision. I have no idea what is going on inside, except the duration and some information about the patient. So I need to be clear from the very beginning, what the fuck does he mean by blurred vision? That's number 1. So this is a vision loss, according to the lady, which has been, luckily, temporarily. It's not persistent or not permanent. This will lead me to the next step in this case, which is the analysis of the vision problem. How do you do analysis of the vision problem? Like any other symptom. How many points?
8/8, okay.
Thank you. Which are previous, onset, course, duration, exacerbating and relieving. With examples, please.
Okay.
Association and timing if applicable. What are the associations? Those are the twins. And what is the twin for vision loss?
Headache.
Headache. And what is the twin for the headache?
Vomiting or
I will carry your headphones. انت لسه قايلها.
headache versus vision.
Vision, headache and vision. Both are together. They are always together. There is no way you will get a case of a headache without asking about the vision, and there is no way you will get a case of a vision problem and you should not, or you do not ask about the headache. They always come together. This is the most important one in your life till you finish the exam.
Okay.
So this is how to ask or to how to do analysis of any symptom, including the vision problem. So 1, what do you mean by vision problem or the blurred vision? I have temporarily lost my vision, and that lead me to the 8 out of 8 points. Then this will lead me to the system involved. What is the system involved?
System involved here, neuro.
Thank you. Did you do full analysis of the neuro?
No.
Why?
I forget.
What?
عملت
Okay.
جزء منه.
So we need full. Yes, you did partially. That
Yes.
P stands for previous. System involved here is the CNS. So I need to ask all the questions about the CNS, like the confusion, loss of vision, weakness, sensory problems, any numbness or tingling, any problem with your gait, controlling your bowel habits, and so on. Motor, sensory, autonomic, aura symptoms, loss of whatever function. This will most likely be how many questions? 10 questions, maybe? Maybe.
Okay.
And this will lead me to the differential diagnosis. This is a differential diagnosis of painful loss of vision. Painful loss of vision. The differential for that in 99.9% of the time is, do we have an abbreviation, Dr. Muhammad?
TIMS.
TIMS. Thank you, sir. And the TIMS stands for T, temporal arthritis. I, idiopathic intracranial hypertension. M, multiple sclerosis. M, migraine. And the S for space occupying lesion. Choose which one of them can fit your case. Obviously, the temporal arthritis fits the best. Do you agree?
Yes, here.
Agree. So this will lead me to getting a diagnosis within 1 to 2 minutes at most by asking 4, 5, 6, 10 more questions. I do not mind. That's a total of 10 questions, 8, 10 more. Those are something like 30 questions. How much time does it take you to ask 30 questions? 2 to 3 minutes. Is that exam applicable? Yes, it is. So I am keeping an eye on the time frame because this is the most problematic shit that happens in the exam. Analysis of the diabetes and hypertension here comes as a second priority, not the first.
Okay.
Because I'm not expecting it to be a TIA in the first place. But needless to say that I need to confirm that this is temporal arthritis. What else could I expect in a case of temporal arthritis?
Jaw claudication and maybe the proximal meniscus polymyalgia rheumatica.
Thank you. So I'm expecting to have some general symptoms like fatigue, like
Fever.
shoulder problems. What kind of shoulder problem? Is it weakness?
And it's weakness.
Stiffness.
No, it's a stiffness. Yes, stiffness.
It's not going to be weakness. Plus having claudication of the jaw. Claudication of the jaw is simply less blood supply going to the muscles controlling the jaw. So the jaw is lacking blood. The jaw is ischemic. And people use their jaws most likely when they are eating or
Talking.
Speaking or talking. Thank you. No way this lady would be eating something when she has the headache and she lost vision. Most likely she was trying to speak or to talk. So did you have any problem with your speech at that time? She will tell you, yes, it was slurred. It was not as usual. And this is a sign of claudication. It also can indicate TIA, by the way, because TIA has no specific presentation. And this is another misconception that we need to fix. TIA is simply speaking a temporary loss of blood supply to a certain part of the brain. Which part? Virtually any part. So it can present with a loss of speech, loss of vision, loss of memory, loss of taste, loss of whatever. So that's the first step, which is the history part. Following that, and we did agree that this will take 2 to 3 minutes according to the schedule. Moving on, we have an examination. And the examination, as I have written on the screen earlier, that we start with the basic examination. And thank you, Dr. Muhammad, for doing so. One of our dear friends had a case in the exam, which was Takayasu arthritis. It was an unfair case, but the only clue in that case, the presentation of which was blurred vision, by the way. And that was in the UK. And the only clue in that case was there is no pulse in one arm. So the basic examination, starting from the hand, moving proximally, is very much important. And it takes quite a short duration of time, 15 to 20 seconds, 30 seconds, pure inspection like you do in any clinical station, collects a lot of valuable information, and it gives a professional impression to the examiner that you are not frozen, giving your brain a break for 15 seconds to consider your next step, which should be the target examination. And Dr. Muhammad, thank you for thinking before acting regarding the targeted. The targeted examination is according to the presenting complaint. We will go to the pitfall paper and mentioning that now. I may have in the exam a lady with rheumatoid hands, but the lady is presenting to me with a shortness of breath. What should be the targeted examination here, Dr. Muhammad?
I must examine the chest and the heart.
Thank you. The chest, the cardiopulmonary. However, yes, because of the stress of the exam, and this is a usual fact, your brain deceives you, tending to examine the hands, the most visible thing that you can see, the most obvious one, forgetting the chest examination, which is the presenting complaint, which is automatically minus 10 marks in the exam, which is catastrophic because you lost the whole exam for nothing. So that's why I did mention that we should write down the complaint next to the patient's name on the paper from the outside before getting in with the stress. Moving on. After the target examination, we will get to the target examination in a minute. After the target examination, so this is the history part, or let's put it this way. So if we are going to do it, so let's do it properly. So here we come. This is the history part. This is the examination part. Then comes the part where we get history in order to, why do we take social history, Dr. Muhammad?
Most of it.
Sorry.
I
تعال
took
اقول تاني
social
كده.
help. social
Why
انا
do you
خدت
take social history?
عشان offer help و driving.
Thank you. This is what I'm working for. Again
Yes.
and again and again. Simple, very straightforward concept. Unfortunately, a lot of us will forget it with the stress. Why do I take social history? To offer help. Involve the occupational health officer, the social worker, and that's it. In 30 seconds or even less. And this is a full mark for the support. Please don't forget it. Then comes the past history, if not checked, the medication history, and then comes at the very end, the closure. How would you close the case? What was my concern one more time, Dr. Muhammad?
The diagnose and will it occur again.
Thank you. And for that reason, I emphasize this point again. Please listen to the concern, not to hear it. There is a huge difference. So when it comes to any closure, as we discussed before in station 2 and in station 5, there is a certain way of doing that. And how many steps, Dr. Muhammad?
6 steps.
Thank you, sir. عجبني ان انت تفتكر الارقام. I like it that you remember how many points, and this is the way not to forget any, although you forgot some here and there. But this is lack of practice.
خلينا بفتكر الارقام بس.
You are doing great. So we will start with the presenting symptom or symptoms. Then we will name the disease or the diagnosis, the most likely one. And that needs a definition to define it. Then you will form a multidisciplinary team. This team will run investigations, keeping in mind that this is an urgent one to be done. And later on, we will arrange for another meeting to discuss the results and the plan of management, keeping in mind the 3 bonus points that we discussed earlier, which are if you are going to, what are the 3 bonus points, Dr. Muhammad?
Admission or not.
Admission or not. If you're going to admit me, to tell me, and
start or stop any treatment.
Start or stop any treatment or practice, and
painkillers.
Painkillers if appropriate in the case. So those are the way we finish station 2, 5, and the long case of the MRCPI, obviously under 30 seconds, maintaining the fact that you do not have enough time in the exam. So let's apply that to your case now, Dr. Muhammad. You are suspecting that the lady, we will get to the differentials in a moment. You are suspecting that this lady has temporal arthritis versus a low possibility of having a TIA, but still exists. What do I have? Will it happen again? You have 30 seconds. Go.
Okay, Mrs. Stewart, your loss of vision, your transient loss of vision, most probably is due to a disease called temporal arthritis.
Let me stop you here for a second and emphasize the importance of showing some sympathy, please.
Okay.
شوية حنية بقى. عايز بقى دكتور محمد بتاع زمان بقى، مش على الشقلبة كده. اتفضل يا فندم.
ماشي ماشي. Okay, Mrs. Stewart, your symptom was coming with transient loss of vision is most probably due to a disease called temporal arthritis.
Most likely.
Most likely. This disease is an autoimmune disease in which your immune system, which is supposed to defend your body, it attacks your body. So to be sure about our diagnosis, we will form a multidisciplinary team, including the neurology doctor and multi-specialties to do some
Do not
investigation.
mention the specialties because you do not have time. You are stressed out. You may forget one, and the examiner is waiting. Keep it as general as possible, an MDT, and that's it.
Okay, we will form a multidisciplinary team to run out some investigations, including an urgent CT brain, an urgent imaging to your brain, and we will arrange another meeting to discuss the result of these investigations. Is that okay, Mr. Stewart?
Would you like to take the full mark in the concern?
And about it, we can occur again. Yes, it may occur again. So we will do these investigations and hope we will give the proper treatment in order not to occur again.
Thank you. So I am sorry to tell you that the vision loss that you have experienced is most likely due to a condition called temporal arthritis, which is an autoimmune disease. By that, I mean a disease in the immune system, which is the system defending your body against infections. In your case, it is misdirected to attack your body, causing your symptoms. For that reason, we have to form a multidisciplinary team, which will run urgent investigations for you, including some blood testing and imaging, and we will arrange for another meeting to discuss the results. And as regards your second concern, if this may happen again, I am sorry to tell you that there is no possibility or there is no guarantee it may not happen again. In other words, it can happen again, unfortunately, and that's why we need to do our maximum effort to get a proper diagnosis and start you on a proper treatment. 30 seconds up to 1 minute, and that's it. Life is good. Back to our differentials. Temporal arthritis, classical picture of having a unilateral headache, which is pulsating in nature, along with a tender scalp, which is non-specific, but the more specific part will be the claudication, with or without giant cell arthritis in someone above the age of 50. This is the American Rheumatology Association criteria. Then the second one is idiopathic intracranial hypertension, or any form of increased intracranial hypertension or increased intracranial pressure. And the most likely for the idiopathic is to be associated with the cardinal sign is
weight gain.
Weight gain, most likely in a young lady who has been gaining weight. So there is no idiopathic intracranial hypertension without weight gain. Moving on, the next part of the TIMS is the multiple sclerosis. Multiple sclerosis versus migraine. How would you differentiate between both?
اوكي multiple sclerosis بيبقى recurrent attacks يعني time و place يعني.
Okay, so the attacks or the occurrence of multiple sclerosis has to be disseminated in time and space, plus
recurrent.
the nature of the pain, plus involving motor, sensory, or autonomic in a younger age population. In contrast to the migraine, which has a usual presentation of having, in most cases, unilateral headache. However, it can come bilateral, throbbing or pulsating headache that is lasting for at least how many hours?
At least 4 to 22.
4 hours up to 3 days. Yes,
to
72 hours. So it does not fit with the migraine, and it doesn't fit also with the clinical picture of having some constitutional symptoms or having shoulder problems, leaving us with the last one, which is the space occupying lesion. This can be virtually in any part of the brain due to cancer myths, or it can be in the pituitary gland. Pituitary gland is either due to a prolactinoma, which is the more common form, versus a pituitary adenoma secreting growth hormone acromegaly. This is unlikely in the exam unless it's a spot diagnosis. Prolactinoma being the most common, followed by cancer myths, and this was the diagnosis in the last 2 diets. Do you agree?
Yes, sir.
And the major difference here, that space occupying lesion is usually reversible or not?
Not reversible.
Yes, it's irreversible. TIA, sorry, temporal arthritis is reversible. Idiopathic intracranial hypertension, on and off. Multiple sclerosis in attacks. Migraine is also in attacks. So once you have a painful vision of whatever sort, always go to the TIMS. This is in the Bitfall paper. It's usually in 99.99999% of the time the diagnosis. On the other hand, TIA is another possibility, and that's why you need to make sure that this is the correct diagnosis before giving instructions to the patients. Back to our fundus. What did you see in the fundus?
اوكي هبدأ الأول من التلت اللي بره preference.
Okay, so since we do this together, me and you, let's make sure that everybody is on the same page. So
Yes.
this is how you get to see the fundus in the exam? No, you actually get to see a certain part of the fundus. Usually you land on the peripheral part of the retina. And we will do the description according to what happens in the exam to maintain the fact that we are realistic for the exam. So most likely I'm going to hit the peripheral retina, and this is going to be zone number 1. Then I'm going to follow any blood vessel towards the disc, and this is going to be zone number 2. And then I will take a survey of the whole retina, ending up by asking the patient to look at the light source, putting the macula in line with your vision to see the macula. So essentially we have 3 parts. You can classify it into 3 parts in order to identify how to see it per se. So the peripheral retina, what do you think about the peripheral retina here, Dr. Mohammed?
As a peripheral retina, I see no hemorrhage, no ischemia,
And
pink.
What color is it? Pink. Pink being the normal color, so most likely this is a healthy peripheral retina. Moving on, if we move towards the disc, let's zoom in here a little bit. If you move on towards the disc, does it look like a normal disc, or there's a problem with this? It's normal. Why? Because
Normal.
it is not well circumscribed. This is normal. Not is normal. To make things easier. That's the first point. And the blood vessels at the disc sites are originating from bigger families. They have roots, they have origins. مش شوية صيع جايين. So they have respected origins, not haphazardly distributed. And moving on from that part to the macula. The macula, what you see in the exam is what you see on the screen, a clear pinkish background. This is the normal looking macula. If there is any additives, this will be maculopathy. Let's think about it as having a pizza. If the pizza is empty, that's normal. Let's put it in a different color because we will need the yellow later on. So if the pizza is empty, that is a normal one. But Dr. Muhammad, what if we have a yellowish additive to the pizza? What would that mean?
You reach the exudate.
Exudates. And what if we have a red additive to the pizza? What would that mean?
Hemorrhage.
Hemorrhage. Bleeding. Thank you. And if we have a black one, what does that mean?
Scar or pigmentation.
Scar of phototherapy or?
Pigmentation, retinitis pigmentosa.
Thank you, sir. So the normal one should be empty, no signs of maculopathy. And if there is any additives, I would say why. So what is your diagnosis for the slide on the screen? And we start as usual, zone by zone. I'm describing what I have seen to the examiner, and this will keep things in order, to the point, and looks and sounds great. So Dr. Muhammad, you said that this is a normal fundus. Why?
Because there is no exudate, no hemorrhage. Peripheral zone, first zone, it's normal.
Okay.
And then going to the disc, it's not well circumscribed, so it's normal, and no coloration, yellow or hemorrhage.
Let's
And
make
the
this simpler. So this is a normal disc based upon the fact that the peripheral retina looks well perfused. No abnormalities detected within the disc, and there is no sign of maculopathy.
Yes.
Easy, straightforward. It depends on your visual presentation more than a verbal one. And that's to make things in order. And we can apply that to whatever case. So let's do one more, me and you, Dr. Muhammad. Take a look at that and tell me, what do you see? And take here 20 seconds to think about it.
Okay.
Okay, let's go.
The peripheral retina, there is some exudate in it, dots of exudate, and
we do not care about exudate in the peripheral retina. We care more about
ischemia color.
Color. Is that normal color? Is that pink?
No.
Ischemic. End of story. Moving on.
Yes.
Let's follow a vessel here. Tell me, what do you see? Any problem with the vessel itself?
No.
No. Reaching to the disc, is that a normal disc?
It's well circumscribed.
Well circumscribed, partially well circumscribed, almost.
Yes.
So is that a normal disc?
No.
I would say it's normal.
It's well circumscribed.
Take a look here and take a look there. You still can tell that both are almost the same. One part or one side is more shiny than the other, but still you cannot draw a full circle around it. We will get to that later on. So the disc here is normal. Any blood vessels coming out without origins, without roots?
No.
No. Thank you. Moving on. Tell me about the macula. Do you see any additives to the pizza?
Yes, there is yellowish exudate, and there is hemorrhage.
Okay, so 1 is going to be an exudate, and 2 is going to be a hemorrhage. The difference between 2 and 3, 2 being a bigger type of hemorrhage, and 3 being a smaller one, a dot one, which is absolutely useless. So what is your overall diagnosis for the slide in hand?
في عندي اسكيميا في الاسكيميك، في ماكيلوباسي وفي اسكيميا في الفندس في
I agree.
ischemic
How
retinopathy.
to pronounce it?
Okay, there is ischemic retinopathy.
What kind of retinopathy? Is it
There
diabetic, maybe?
maybe
Is it hypertensive?
no
No, there is no
hypertensive.
sign of hypertension here, per se.
Yes.
Diabetic, is it proliferative or non-proliferative? Do you see any new vascularization around the disc?
No.
So this is non-proliferative. So your overall diagnosis for this
Yes.
case would be non-proliferative diabetic retinopathy with signs of
Maculopathy.
maculopathy. Why? Give me the facts one by one, zone by zone. Go.
Okay. Retinopathy in the peripheral zone, there is ischemia.
Not ischemia. It is pale peripheral retina.
Okay.
Then
And there is at the disc, there is no new vessels, and it's not circumscribed. And then at the macula, there is excess and hemorrhage.
so your overall diagnosis is,
Non-proliferative diabetic retinopathy with maculopathy.
and the trick or the pitfall in this case, that this case will need an urgent what?
Urgent
This is the summary of analysis of any chronic condition. We did work out the closure, we did finish the concern, we did ask about the claudication. So it's a well done case now, it's 100% done. Thank you, Dr. Muhammad.
Thank you, Dr. Muhammad.
See, it's fun. A little bit exhausting in the very beginning, but later on, with proper practice, you are not practicing, I can tell. With proper practice, believe me, it's going to be straightforward, easy, and you will have a lot of fun in the exam. So thank you, my friend, again. If you have any question yourself or anyone, shoot.
Thank you, sir.
Should we offer prednisolone in the closure?
What do you think?
I think we
You
should
need first to confirm the
to preserve the
diagnosis.
vision.
And in order to
All
confirm the diagnosis, you need to rule out the most imminent, most likely other differential, which is the TIA. So at least for the lady, for the time being, I will go with an urgent CT before offering anything. Plus, the lady has regained vision in her eye, only one attack. So the steroids can wait till the urgent CT is done.
Thank you.
Thank you. Any other question? Anyone having fun except me? Anybody loves me? No one?
Thank you, Dr. Muhammad. Keep.
Thank
Okay,
you
guys.
so much.
It was a good one. If she has prolactinoma, would there be, there's a question in the chat. Wait. Would there be any specific questions? What do you think, Dr. Moon? Open up your mic. Dr. Moon, we have a question from her.
Isa.
Prolactinoma. So a prolactinoma, what do you think the vision problem would be?
So bitemporal hemianopia.
And how would you ask about that?
Do you have any problem in your
Bitemporal, is it central or peripheral vision problem?
peripheral vision problem?
Peripheral, how would you ask about the central vision problem?
Is there any
Reading.
problem in seeing at the side of the road?
No. Central vision problem, having problems with reading, playing Candy Crush on her telephone or catching her cell phone, or playing PUBG for the guys and the gentlemen who play PUBG or Call of Duty. This is the central vision when someone is holding his phone, and I'm making a little bit sarcastic here in order to remember it. Peripheral vision problem, on the other hand, will be bumping into objects because she cannot see the peripheries, or if she cannot see the sides of the roads. So this is as regards the presentation. Both of any case in vision, usually it presents with blurred vision. And that's why I need to ask about what do you mean by blurred vision? If she tells you I cannot see properly, ask about central and peripheral. If she tells you that I have lost vision, that's a different story. Did you regain it or not? Temporal versus permanent vision, loss or double vision. And that's why I need to be clear from the very beginning. Plus, what else can you tell me about prolactinoma?
Sir, in prolactinoma, there is a galacturia problem. So should we ask
I
about
don't
this?
think so. There is something far more important when it comes to vision. What is the most important twin in your life?
Headache. Yes.
Thank you. So she has a vision problem, and in order for me to get a differential, I need to ask about having a headache or not. So the lady would definitely have a headache. This is the first thing that I need to establish before anything else. Then comes the rest of the symptoms of prolactinoma, if there is any. And please remember that the ladies are far more tolerant to prolactin, meaning that what is the difference between prolactinoma presentation in males and in females? Dr. Moon, can you tell me, please?
So in case of female, there will be vision problem or headache. That would be the main complaint, I guess. And in case of
Are you married?
male, the
Have a
galacturia.
boyfriend, fiance?
Yes, sir.
Are you married? Yeah, you're married, right? You can tell
No, sir.
that you, okay, if you have a fiance or a boyfriend or a brother or a father, you can tell that all guys are impatient. We do not have patience. We do not wait. I want my food now. And we are always complaining about something, correct?
Okay,
As
sir.
guys, we do complain a lot as guys. We want everything to be perfect. And that's why guys complain very early with the headache and the vision problem. Later on, they complain of the infertility, which is the erectile dysfunction, and this is going to be late. On the other hand, the ladies, those are sisters and mothers taking care of the children, of the husbands, and they tolerate a lot of shit in life, so they do not complain easily. So their first presentation is going to be the other way around. They will present with amenorrhea, which is the form of infertility, and later on they will start complaining of the vision and the headache. They complain late because they are more patient.
Okay, sir.
So this is a shout out for the ladies, and this is the way you will never forget it, I think.
Okay, sir. Thank you.
Thank you. Now you will remember that all guys are bad, but we need them in life, otherwise we will not be able to live. You have to tolerate us. Just saying. Okay, any other question here? Yeah, and I made someone laugh, Dr. Karim. Okay, any other question? Anyone having fun? Me? Thank you for mentioning.
What's your
Yes, sir.
opinion about the
I
CT
disagree.
in case of
I disagree.
TIA?
What about the CT?
Because the guidelines, they said that no need for, you will
Thank
not
you
do
for
any
the proper,
urgent CT.
good question. New guidelines. Let's
Yes.
agree that about something. First of all, this is the basis exam, and those motherfuckers do not give a shit about guidelines. And if the examiner believes that I need to do a CT, he wants a CT, the examiner, and I do not mention it, it's fatal. Correct?
Yes.
And if he doesn't want a CT and I mention it, he will disagree and he will tell me there is no need to do the CT. but I would rather say it rather than not to say it. Not saying it, potentially fatal. Saying it is okay. So ABC, whether there's guidelines not to do CT from the very beginning, eventually a CT will be done, because when you refer it to your consultant or your senior, he will not risk going to the court because he did not offer a CT. He will do it. Eventually, he will do it. He will have to do it. So I would rather say I would do an urgent CT, take my chances with that, which is going to be far better than not mentioning it and the examiner is waiting for it. You get the point?
Yes.
So if you're an Arabic speaker, let me say that in Arabic. أنا أقول له أعمل CT سواء عاجبه أو مش عاجبه. ده أضمن لي إن أنا ما أقولش خالص. لأن أنا لو ما قلتش خالص وهو مستنيها هيقول لي روح لأمك. وأنا مش
ده
عايز
اللي بيحصل
أروح
في الامتحان.
مش فاضية. Okay. I think I'm losing it. Okay. Should this lady with your option? No. Thank you, sir. So no admission till we confirm the diagnosis, and if it's confirmed, she will not be there. Okay. This is another question. Who asked this question? تعالى. تفتحوني ليه؟ كنت قاعد ساكت محترم. دكتور طاهر. اظهر وبان عليك الأمان. دكتور طاهر.
Yes.
When will you admit a case of a TIA? اللي جبته لنفسك بقى.
No. You said that the patient has painful vision loss. So
no.
What type of differential?
This is a confirmed diagnosis of TIA. When will you admit the patient?
Okay. It's recurrent TIA.
What do you mean by that?
Crescendo TIA.
Which is more than
3 times in a week. 2 times in a week.
2 times a week. And that's why 8 out of 8 points come here very handy. Previous will make sure that you are not going to forget it. What else?
Patient on anticoagulants.
Thank you. Patients on anticoagulants.
So
this is someone who requires an attention and admission. What else?
Stroke and evolution of it.
No, sir. Recently diagnosed AF. And previously the ABCD score, but this is obsolete now. Can mention it as number 4. Those are the criteria to admit someone with a TIA.
About in temporal arteritis, if we think that the vision is compromised, then what about the urgent steroid injection and admission?
Okay, if the vision is compromised and the patient is presenting to you with a vision loss that is due to temporal arteritis, definitely you will blast him with the steroids. But the lady has recovered, and this is the first attack. So I would rather take my time, do the CT, rule out the TIA first, at least do what I can to rule out the TIA, then I will start on steroids. Oral or injection?
Oral.
Usually oral. Small dose or large dose?
Small dose.
Large dose.
No. This was my mistake in one of the exams. It was a communication case, and the examiner was a motherfucker racist. He wanted to deduct any mark from me. He gave me 15 out of 16 in that communication case of giant cell arteritis, because I said in the discussion, not with the patient, that I will start the steroids on a high dose. It should be smaller dose and titrated upwards, not the other way around. Experience. I have failed so many times and I love it. Okay, so thank you guys. It was a good one. Please ask me, give me cases, shoot something in the Telegram. This group is done for a reason. And I hope that you had fun like I did, and have a good one.